Outcomes for multiple myeloma patients have improved dramatically over the past decade. This has come about as the result of the introduction of a whole new class of novel agents which we can apply to therapy. We have had over 6 drug approvals by the FDA in the United States in the past 5 years. The backbone of therapy has now become what we call an immune modulator. That is generally the drug lenalidomide at diagnosis and pomalidomide at relapse. That is usually combined today with a proteasome inhibitor. Bortezomib is the most commonly employed drug at diagnosis, followed by carfilzomib or ixazomib at relapse, although we are beginning to see use of those other drugs also in newly diagnosed patients. Because we have these new drugs, we have seen dramatic improvements in survival. We have estimated overall survivals now in the 8 to 10 year range, particularly for those patients with low-risk disease. We tend to divide patients into those who are healthy enough to move to autologous stem cell transplant and those who are more frail who need a more continuous therapy approach with lower doses of drugs. In the United States, the gold standard of care today is then the combination of an immune modulator drug such as lenalidomide with a proteasome inhibitor such as bortezomib and corticosteroids. Patients who receive these drugs have almost 100% response rate, so their symptoms improve quickly. Those patients will go on to either receive a transplant or receive continuous lenalidomide as part of their therapy. There are other things we worry about in myeloma. We worry about the genetic risk of the disease, and we divide patients into higher or lower risk. We would tend to favor a more aggressive approach in the higher risk patients, particularly use of a proteasome inhibitor for longer periods of time. Just recently, the FDA have for the first time approved a monoclonal antibody in the treatment of newly diagnosed disease called daratumumab, which targets CD38 as self-surface antigen. This study, which combined melphalan, bortezomib, and prednisone with daratumumab, showed a distinct advantage to the addition of the 4-drug cocktail. Those 4 drugs are rarely used together in multiple myeloma in the United States because melphalan has really fallen out of favor because of its toxicities. But that does open the door perhaps to using daratumumab and other combinations in newly diagnosed patients. We expect that will further improve survival, depth of response, and quality of life because of rapid symptom control. It does also raise the issue of economics, however, because all of these drugs, particularly those who have been recently approved, are quite expensive. And when given in combinations over long periods of time, the cost has become somewhat prohibitive. So we are beginning to explore ways in which we can shorten the duration of therapy perhaps, obtain a deep remission more quickly, and try and reduce the economic burden of the therapy, but we are still in a transition period for that initiative. Because of the increasing costs of drugs, the convenience of using them, particularly for patients who live long ways from the hospital, and the need to strategize dependent on genetic risk of the patient, we do have to do some planning when we start therapy, which looks at whether we should use all of our drugs early and quickly or stagger or what we call sequence those different agents over time. So we do start out with a definite plan in place for our younger, healthier patients, which is usually to use all of our best drugs as quickly as we can. We believe we may even be able to cure some patients if we do that, and we are aggressive enough and give therapy for long enough. So for a younger patient, it would be very common to receive 3 drugs for 4 or 5 months, have an autologous stem cell transplant, perhaps some consolidation, and then maintenance therapy over many years with low levels of drugs that are given conveniently through an oral administration. In those patients, we are using all of our best agents in combination early, but we already have a plan in place should they relapse where we have second-line drugs which are available to us. In a more elderly, frail patient, I think we're more inclined to be conservative in the choice of drugs that we use. We're more interested in quality of life than in longevity often in that situation. And we'll tend to use our most convenient, best tolerated drugs as long as they are still fairly effective early on, and perhaps save some of the more toxic, inconvenient drugs for later in their disease course. We do know that almost all myeloma patients will relapse at some point, so we do have to have both a strategy for initial treatment and a strategy for relapse as well.